Hi, and welcome to Healthy Living. We are here today with Kelly Presnell, Director of Marketing and Public Relations here at Hilton Head Hospital, and we have a cool show. I'm really excited today.
Yes, Dr. Michael Gilbreath. He's one of our gastroenterologists that's on the medical staff here at the hospital, and he's going to talk about something that affects a lot of people, which is heartburn, reflux, GERD, what all that means, symptoms
Treatments,
of that, all the treatments, and you can tell by the show that you're about to see that they're passionate about what they do, they really enjoy what they do, and want to educate the community on these certain diseases and conditions.
I'm really excited to hear this because I think this is the reflux, all the gastro stuff are things that we all experience.
Right.
And he's going to share with us too when to actually come in and seek the advice of a professional.
That's right.
So let's talk with Dr. Michael Gilbreath.
Excuse me. Hi, can I get through, please?
Dr. Newman.
You know, there has to be a better way. A way to skip the ER waiting room. Like this lady over here. All she did was log on to inquicker.com to hold her son's place in line. Now they can wait at home and skip the ER waiting room. Now, which would you choose? This or this? Hold your place online at inquicker.com and skip the ER waiting room. Ooh, is that hot cocoa? Oh, help yourself.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Once again, we are here on Healthy Living. Dr. Michael Gilbreath is joining us. He is a gastroenterologist, and we're talking about things that I love. It's really interesting. Before we turn the cameras on, it was fun to even chat with you because one of the things you said that I think stuck with me is that you still love what you do. You're very passionate about it. And you said it's because it's a diverse field.
Oh, gastroenterology is a diverse field. As I was mentioning, we deal with disorders of the esophagus, the stomach, problems with the pancreas, the bile ducts, the gallbladder, the colon. So it's a big spectrum of diseases, and that's what keeps it interesting.
And I was going to ask you, what do you typically see here in the Low Country is there something that you see more often than not?
Oh, we have a pretty good spectrum of patients and diseases here. I mean, it's an unusual area because it's a good cross-section of America. So, no, I mean, we see
everything.
We see everything that comes down here.
Well, I would love to talk with you, and I think we did a little bit of sharing before about the dreaded word reflux. I hear that the older I get, the more I hear it, but I also hear it in a lot of young adults. What is reflux? Is that a term that's just kind of thrown around loosely, or is it a true syndrome?
It can be.
Okay.
And years ago, people used to just talk about things like heartburn. And that would be more traditional symptoms where the stomach makes too much acid and some of it literally starts going into the lower esophagus. And people would develop pain or a burning sensation. And they'd say, oh, it's after you eat. Different cultures called it different things. When folks come in from more of the Mediterranean part, they call it agita. And in medical school, they don't teach you that because whenever the ladies come in, they'd always say, doctor, I have the agita. The agita. I said, well, what the heck's that? And then someone said, the acid. But that's exactly what most people describe as a sense of heartburn. But over the past 20 or 30 years, our understanding of acid reflux has really expanded. And we know that it can now cause a lot of other diseases besides traditional heartburn from the acidity coming from the stomach to the lower esophagus. Other things that can cause, or sometimes people are experiencing chest pain. And they'll come in complaining of chest pain and they're in the emergency room or their doctor's office.
Scary.
They've seen the cardiologist, the ER doctor, and they say, well, it's not your heart. And they say, well, what is it? It hurts.
Because it hurts.
And sometimes people say, well, it could be acid reflux. Maybe you should go see the gastroenterologist second.
I have like 25 questions. Is there a time of day that most people experience reflux? Is there a gender or demographic person, a typical person who would have reflux?
In terms of time of day, people can experience at any time, and there's an enormous amount of diversity. For people like myself, I'm more of a nocturnal refluxer, meaning that literally as someone lies down, just not having gravity on your side can cause a lot of the acidity to come up, especially if you eat later in the day. For people that eat earlier in the day, usually not a problem. But some people get reflux so bad that literally they can have it all day long.
Is it something that is there a genetic component? Is it an environment? Is it what I eat? Is it my weight? What causes it?
They're all very good questions.
Yes, exactly.
Because there are a number of things that can cause acid reflux. From a medical perspective, most of the time what we're dealing with are disorders of the lower esophageal sphincter. And usually right where the stomach and esophagus meet, there's a small muscle. And that little muscle normally stays closed. Sometimes as we age, the muscle becomes a little bit incompetent and it can't hold the acidity down like it's supposed to. And literally the acid starts coming up in the chest, and that's pretty classic reflux. But that little muscle normally starts developing very early in life. But if you can think back to the time when your children were very small, when little babies are held by mama, the little babies are always spitting up and spitting up and spitting up. That's because a lot of times early in life, that little muscle hasn't fully developed yet. And in some people, it never does develop in their whole life. They're constantly coming in, bringing up and spitting up, and they've always had problems with acidity. But in most of us, greater than 90% of the people, as we start to develop, the little muscle that becomes competent and the acid reflux and spitting up goes away. And mama stops calling because the baby's doing so much better. But it's very common for little babies. I'm sure you've seen mama walking around with little.
Oh, absolutely. I think, after 3 kids, I did it for like 12 years. Exactly. Now, obviously, there's no way to exercise that muscle. So that would be the genetic part of it, right? Some people are just more.
That's one predisposition, is that some people never fully develop. But there are a lot of other things that can cause reflux later in life. It's very common that as our diaphragm becomes weak, the stomach literally can start to pull up into the chest, and that's called a hiatal hernia. And that actually happens as more and more times go by, so hiatal hernias develop later in life.
So what causes that again? The diaphragm?
The diaphragm is the breathing muscle. And normally the esophagus goes down right behind the heart, and the stomach sits in the lower abdomen. Just like most other things, the muscle, actually the tendinous sheaths that hold everything down can become loose and the stomach can start to pull up. But any connective tissue in the body, as time goes by, can kind of loosen up and things can move. One lady explained it to me best when she came to the office, and she says, "Doctor, do you know why I'm here?" And I said, "No, what brings you to visit with me?" And she said, "I suffer from the sags, bags, and drags. Everything is just going."
That's exactly right. I mean, it may not be true.
That's what happens.
It's real. It really is.
It's like everything starts to prolapse and herniate as the birthdays go by.
What is the treatment or interventions? What are interventions for things like a hiatal hernia? And then again for reflux?
Usually, if people have simple reflux, and it's fairly classic, they say, "I go out to eat, I have a spicy meal, I can feel the burning that comes up afterwards, I can take some Mylanta, it seems to get better." That's pretty much diagnostic. And for most of those people, we start with very simple over-the-counter things like Mylanta and Maalox. They relieve acidity well, and they're good things.
Is that what it does? It just relieves the acidity?
It literally can help to neutralize the pH. So that's the first pharmacologic therapy, but for a lot of people, it's simply lifestyle changes. If the symptoms are very mild and it's early on, we'll say, well, obviously don't eat late at night, because if you do eat late at night and then you lie down, gravity's working against you and the acidity can come up. So we'll say eat earlier in the day and give it about a 4-hour gap from the time you lay down, from the time you eat to the time you lay down. And for some people, that's all that they need. We talk about foods that can promote reflux, things like coffee, chocolate,
caffeine, peppermint, I got them all listed.
Alcohol and mint, you do. And by cutting back on those things, it will help a little bit. As you so eloquently pointed out, obesity in the United States, big problem. Literally the weight from our abdomen can push in the stomach, and that can promote reflux. So weight loss will help, eating earlier will help, avoiding reflux-producing foods. trying simple over-the-counter preparations. For some people, we also recommend, since nocturnal reflux is such a big problem, elevating the head of the bed
I saw that.
or getting a little foam wedge. And a lot of people, that will help too, because gravity literally just helps to keep things down. A lot of people eat too late. So those are simple things to start with.
Okay. Well, and what I was going to say real quickly is, I know that some people say, oh, if I have this reflux, maybe I'm lactose intolerant, maybe I'm gluten intolerant, maybe I'm this, maybe I'm this. Is that, are we moving on to the next? Yeah,
We're moving on to the
right.
next thing.
Okay.
Nope, there are a lot of things when people have discomfort or symptoms and they're not quite sure what's causing it.
Okay.
And neither are we.
Okay.
So you have to be very specific when you ask people what symptoms they're having. Because some people give a classic, as I mentioned, if you give a classic history, I eat something, I eat a big meal, it's full of spice and coffee, and I had a couple cocktails, and I feel the acid coming up and it's burning, and I drank some Atlanta, it went away. Good enough. That's a reflux, you don't need a medical degree to figure that one out. Over-the-counter things like Mylanta will help. When those don't work, you can pick up some very good preparations like famotidine, sold under the name Pepcid.
Yes.
That's what I take myself.
Okay, okay.
But Pepcid, Zantac, Tagamet, they all work well and are inexpensive.
And what do? They do more than relieve the acid or neutralize it?
Right. The things like Mylanta will reduce the acid very quickly, but the problem is it doesn't last very long.
Okay.
So you wind up taking one of those preparations several times, and although it works fastest, you won't get complete relief to last for a long time.
Okay. And then?
But the next step up, which are what we call the H2 blockers, things like Pepcid, Tagamet, and Zantac, they don't work quite as quickly, but they work very quickly. But they can actually get you 6 to 8 hours of relief. So for those things, they work much better, and that's what I would tend to use too.
We're going to take a quick break here with Dr. Gilbreath on Healthy Living. I know you're not going to want to leave. Stay with us. We'll be right back to talk a little bit more about reflux, complications, and treatments. Stay with us here on Healthy Living.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hilton Head Hospital.
We are back here on Healthy Living. We are talking to Dr. Michael Gilbreath about gastroenterology, specifically reflux. It's been really fascinating. I think it's times like this I wish we had a call-in show because I think we would be swarmed with questions. What is GERD?
Very good pickup because, as I was mentioning earlier, GERD can start as what we typically call heartburn.
Okay.
But most certainly over the past 30 years, we've learned that a lot of other things besides heartburn can be caused by hyperacidity or stomach exiting the stomach and going up into the esophagus. So hyperacidity can trigger a lot of other things. Earlier we were talking about classic symptoms of acid reflux, which is heartburn or agita, depending on the culture that you're dealing with. But acid reflux today we think can cause a lot of other problems. It can cause problems with the throat, problems with the upper esophagus, problems with the lungs. So we call those extraintestinal manifestations of reflux or of hyperacidity. So the term gastroesophageal reflux encompasses more than just heartburn.
I see.
We can say that all the other disorders of the throat and lungs can come from reflux as well. The tough thing is deciding what's actually causing the symptoms.
How do you do that?
That's a very good question. One of the things that we talked about earlier, when people come to a hospital, some people experience chest pain, and they've been going to see their internist, their family doctor, the cardiologist, the emergency room, and they say there's nothing wrong with your heart, even though you're feeling pains in the heart. So sometimes doctors will automatically, empirically try acid suppression, thinking maybe hyperacidity is causing this, let's try an antacid. But sometimes people aren't sure, and they say we need more definitive testing.
Okay.
There are a lot of different ways of looking at this, but before we do that, I want to mention a couple of the other things that hyperacidity can cause. Besides mimicking heart pain, we now know that hyperacidity can cause a lot of problems with the throat and problems with the lungs.
For example?
For example, some people get problems with chronic hoarseness, and they're constantly saying, I just have problems speaking. Or they'll complain of chronic cough and think I'm always coughing, coughing, coughing. And I've been to see the otolaryngologist, I've been to see the allergist, I've been to see the lung doctor, and they can't find anything wrong with me. And they said, I should come see you. And I said, do you have heartburn? And they say, no, I don't. And I said, well, why are you here? And then we kind of have to sort things out and work to see, are these throat and lung problems related to reflux or not?
Is it that the acid is actually traveling up that far?
That's a very good question, because we truly don't know in a lot of people. In some people, we think clearly it does.
Okay.
If a person comes in, and earlier we were talking about hiatal hernias, meaning the diaphragm is weak and the stomach's actually now in the chest, literally those folks can lay down at night, and if your stomach is sitting up in your chest, it doesn't take much. Literally, the acid can physiologically just go to the back of the throat. And a lot of those problems have signs of chronic burning in their throat. They can have hoarseness, they can have cough. And if they're aspirating in their sleep and the acidity gets down into their lungs, they can actually develop almost allergic or bronchospastic symptoms that look like asthma. We think that in some people, fibrosis of the lungs can come if they're chronically aspirating and they don't know it.
Interesting.
So it can literally be that the acidity is coming up and literally causing a physiologic change from direct contact. But in other people, we don't think that's the case. Some doctors think that when the acidity goes up into the lower esophagus, it causes a physiologic reflex, meaning symptoms from your esophagus being irritated by the acid go to the brain.
Oh, this is
and
fascinating.
It's the brain that's causing the symptoms in the upper airway or problems with the lungs. But sorting that out can be a very tough thing. So there are a lot of different ways we have to look at it.
I've heard of something called Barrett's syndrome. And what is that? Is that related to this?
Barrett's esophagus means that people have had hyperacidity in the lower esophagus, not for days or weeks or months, but literally for years. And because they've had so much acidity there, literally their esophagus is changing to try to protect against the acid.
Is it like an erosion?
Barrett's is different. Barrett's means that the lining of the esophagus is changing to protect from the hyperacidity, and that change can predispose you to cancers that you normally don't see of the esophagus. I know there's a lot of commercials on TV talking about Barrett's esophagus now.
Exactly.
And we never used to see those, but that's being recognized more commonly in people that have long-standing reflux. The problems with diagnosing these things are some people don't realize that they're getting reflux and that that's what's causing all of their problems. So it's always kind of hard to sort out because some people swear that they don't have it. But it's kind of like anything else. If you get into a bathtub and at first the bathtub's very hot, but after you've been in it 5 or 10 minutes, you don't realize that the bathtub's hot.
True. You don't know what normal is if you've never experienced. Yeah, that makes sense.
When you jump into a swimming pool, it's cold.
Right.
Then after you've been into it, the kids say, oh, I'm used to it. And you acclimate to it very well and you think that this is normal. So there are people that have chronic reflux that swear they don't have heartburn and come to find out they do have severe reflux and it can predispose them to Barrett's esophagus or multiple complications of reflux. Barrett's gets all the press because that's the one that we worry about because it can predispose to cancerous changes. But the risk of cancer is actually very small. So we think that we tell people that the risk is only about 0.5% per year. Having said that, if there are 400 or 500 people on the island that have Barrett's, well, then you will see 1 or 2 cases of esophageal cancer pop up every year. So that's the thing. It's a low risk, but you have enough people, the risk becomes real.
Is an ulcer part and parcel, is an ulcer part of reflux also? Is it a totally separate thing? Is it just stomach related?
Hyperacidity can cause a lot of ulcerations or little divots that occur in the mucosa. But most certainly if you have enough reflux from your stomach up to the esophagus, it can cause ulceration of the esophagus. Some people come in, they have horrible problems swallowing because the esophagus is so ulcerated.
Oh,
we put an
wow.
endoscope down there, we can actually see the large ulcers and food won't go down. And they say food's getting stuck. Other people,
Like strictures almost.
they can develop strictures of the esophagus too. So there are a lot of different manifestations if the hyperacidity has been there for a long time. Ulcers and scarring and strictures of the esophagus. None of those things are things that you want. So if you have a hyperacidity, you really do want to have it treated.
Yeah, that makes a lot of sense.
Like I said, Barrett's gets all the press. We see it. We most certainly keep a close eye on it. But there are many other complications besides.
Can we talk about some of the diagnostic interventions that you do to determine severity, exactly what we're talking about?
Whenever we're
Actually, I think this would be the fun part of your job, getting to do all these kind of fun
It
things.
is, because sometimes it's whenever you get a referral from someone, you have to figure out who's right, the referring doctor or the patient. And sometimes the doctor's right, sometimes the patient's right.
Exactly.
And that's the hard thing. But if someone comes in with complaints and they say, I don't have reflux, but I'm having lung and throat problems, I'm having problems with bronchitis or asthma, I'm having atypical chest pain, and I say, do you think hyperacidity is causing it? And the patient says, no. These doctors are crazy. And I said, well, maybe you're right, but maybe they are. So usually what we start out with is a simple test called an endoscopy, where we have someone literally just take a little scope and we have them swallow it, and we physically examine the esophagus.
Okay, now here's what we're all saying at home. You just do a little thing with a little scope that I swallow. Is that done under sedation? Is it done outpatient? Is it done?
You can do them outpatient or inpatient. Some people can do it without sedation. I have several people that don't like sedation, and they can just sit down and calm themselves down and literally just swallow the endoscope with a little bit of lubrication. Well, I mean, if you watch TV, I mean, sometimes there's these people on the television shows that can actually take a sword and swallow the thing down and not wince. That's a very rigid thing, and they do it without gagging at all.
Oh my gosh.
Now, I wouldn't recommend doing that, but nevertheless.
This is so.
But some people can, and for some people, swallowing that little endoscope is not a big deal.
Okay, so endoscopy is one of the primary diagnostic tools that you use.
Yes, it is. And then sometimes endoscopy can be very telling, because if we're looking for things like Barrett's esophagus or ulcers or cancers, an endoscopy can diagnose those things very readily and quickly. And that only takes about 5 or 10 minutes. You can either tell someone, listen, you really do have significant reflux and you have a lot of complications from it, but sometimes even the endoscopies can be negative. Reason being, you can still get physiologic reflux or hyperacidity that comes up once in a while, but it doesn't actually damage the esophagus, but you're still getting it. So sometimes we look at a patient and we do an endoscopy and we say, you were wrong and your doctor was right, and sometimes we say, well,
the other way around.
The other way around. If we definitively want to know, is there hyperacidity because the endoscopy is negative? The patient thinks they don't have it, the doctor thinks they do, and I really have no idea. The most definitive way of diagnosing this is whenever we pass the endoscope and we look at the esophagus, we'll put a little probe, very similar to this little probe, and we actually clip that probe to the wall of the esophagus. That little thing will hang there, hopefully, for 24 to 48 hours before it dislodges and passes. And that little probe will sit there, and over 2 days, it will record how much acidity comes up in the esophagus.
Oh my gosh, how amazing.
And well, you know, whenever I first started doing this thing, it was horrible because we'd actually have to put a probe on a wire and hang the thing down there. And people walked around with these little tubes hanging out their nose, and people were like, what's wrong with you? But just like your phone has improved, so have those little probes, to where now literally we clip one in there, it broadcasts a little beam to something you wear on your belt, and as it broadcasts that little beam, it tells us how the pH goes throughout the day.
So here's my thought. We have to go here on Healthy Living, but this is just the tip of the iceberg, literally, and we'd love to have you back again. You are really interesting, and you make it, you're a good storyteller. This really helps us, I think, understand and clarify some of the questions that we all have. We want to thank you all for joining us here on Healthy Living. Bye-bye now.